our genetics presentation team. I'm Brenda Gallie. I'm standing up. Hilary Racher, stand up, put your hands up. And Melissa Mills, stand up, hand up. And we actually have a fourth presenter for our team, and it's you. So all of you stand up and put a hand up. Stand up. You need your exercise. In fact, take a deep breath. Thank you. So I will go, if I can manage this. I've not managed this one before. I just push the forward button. Is that right?
Yes. You have to aim it kind of that way.
You have to,
yeah.
I'm pressing the light. Okay, so which is the?
The arrow, right
arrow. Okay, right arrow. Good. Okay. The questions that we will address, we hope, and you will find more that we may have missed. Please jump in at any time. What do my child's genetics mean for screening, other family members, EUAs after treatment, ongoing treatment and risks, and family planning? And then the big one, which we want to very much get to, what do we do if we can't access genetic testing? So first is, what does this all mean? And I'm going to pass this to Hilary. You'll see in the corner of the slide is a little initial. So now it's Hilary.
No, you can stick here.
Okay, we're going to stay put so we can keep efficiently going through the slides. So we had, for those of you that were here yesterday, we had a lovely introduction to genetics from Dr. Helen Damaris and Melissa Mills, who's back up here again today. So a reminder to the group, retinoblastoma resides on chromosome 13. This is an image of what we all hold inside of each of our cells, which is the human genome. So I'll be going into a description of heritable versus non-heritable. And to talk about this, I'd like to introduce everybody to a great new addition to the staging program that exists through the American Joint Committee of Cancer. And retinoblastoma marks the very first cancer to include genetics in the tumor staging. And this was all work done by many of you in the audience today, and we're going to learn more about TNMH staging in future talks at this meeting. So to help illustrate the three different categories, I'll talk about heritability versus non-heritability in the coming slides. Heritable retinoblastoma is defined in the TNMH staging as H1. Heritable retinoblastoma involves the individual who develops retinoblastoma inheriting the mutation in RB1 gene from one of their parents. And this presenting child carries the mutation in all of the cells of their body. Subsequently, in the retinal cell, they develop a second mutation in the adjoined copy of chromosome 13, which leads, in addition to some of the other mutations that Dr. Damaris talked about, the creation of a retinoblastoma tumor in the eye. Heritable retinoblastoma can present in many ways, classically bilateral, but also unilateral presentation, as well as a more aggressive form of trilateral retinoblastoma. To help hit home the terminology from the TNMH staging, in an individual, a parent who is affected with retinoblastoma, they have a 50% chance of passing on their retinoblastoma mutation to their offspring. If their offspring inherit the mutation, they are also referred to as an H1 individual. For those offspring that do not inherit the mutation, the terminology used is H1 for those who inherited the mutation, H0, sorry, I'm already starting to confuse everyone. Yeah. H0 for those who did not inherit the retinoblastoma mutation. For non-heritable retinoblastoma, we refer to them as H0. In this circumstance, as we learned yesterday, all individuals are unilaterally presented. and the mutations reside only within the tumor cells. If you were to look at the cells of the body elsewhere, outside of the eye, there would be no recognized retinoblastoma mutations. There's really two main categories. The first being mutations in the retinoblastoma gene inside the tumor. The second is what we learned yesterday as well, amplification of the MYC-N gene, again, that occurs only inside of the tumor cells of the eye. Neither of which these conditions are heritable. This is only occurring within the eye of the patient. Furthermore, to just expand upon the concept of heritability, the H1 category, a given affected child may be the result of inheriting the mutation from an affected parent, which we refer to as familial heritable retinoblastoma. In addition, there are other forms, non-familial heritable retinoblastoma. We've learned from today's talk already about the new germline mutation. The affected child is still inheriting mutation, but this is from an unaffected parent who developed a mutation in their germ cells, in their sperm or eggs. We also learned a little bit about mosaicism in previous talks. This occurs after the sperm and egg come together. Subsequently, during embryogenesis, the development of the fetus, a mutation arises. This subsequently leads to a variety of different risks that we're still exploring right now. Relating H1's risk back to second cancers, in the situation of familial, all individuals have a risk who've inherited the RB1 mutation of second cancers. The same is true for the new germline mutation, non-familial heritable H1. However, with the 6% of cases with mosaicism, we're still trying to understand and predict what the risk will be. We presume in many cases that they're going to have a reduced risk for second cancers, depending on the distribution of that mutation in the cells of the body. This leads us to a live stream question that we received yesterday. I'll pass the presentation to Brenda to answer this question.
Yes, Abby's been feeding us by email questions from the live stream that we are trying to incorporate as we go. The question is, why is retinoblastoma on the rise in children without a family history? Parents don't have a mutation. So I'll just turn it to the audience. Who thinks the answer is that is a true statement, and who says it's not true? Anyone put up your hand if you think that it is true, there is a rise. And those who think there is not a rise. Okay, the nots win, in my opinion. But there is no there's no data in the world, I think, and Helen could correct me on this, that would support an increase in the overall incidence. And of course, since Abby's sitting thinking very hard, listening to us all now, this is Abby White's explanation for this question, and she's answering the second question, I suspect is artifact of social media bringing people together. More than a few people have impression of numbers increasing, but surely just because they are just meeting more people year on year, and also several of the young centers attract more patients this year due to their treatment approaches. So then she also makes a good forward step and she says, I'll write a blog about this sometime. What do my child's genetics mean for EUAs after treatment? And we do have data published over the years in this direction, but now for the first time, we have what was previously referred to, the first US guideline on retinoblastoma, and it specifically addresses this question, the EUAs for the children. And you can see in the red column, the second column, it depends, the pattern of EUAs depends on the risk that the child will develop tumors in the either eye. And so for the high-risk children, they have examinations before birth, but after birth, very frequently, but they don't need an anesthetic. That's in green. The blue squares are when they probably need an anesthetic, although some centers do not do many anesthetics. Most of us do anesthetics. However, after age 3, I think we don't do many anesthetics for cooperative children, but there always will be children for whom you cannot adequately evaluate their eyes, or they're particularly those with a treated eye with a very complex disease, and you must see the far distant corners of the eye. That isn't for the genetic reason. It would be you'd keep doing anesthetics to evaluate the tumor that was there, that you hope is gone. And so this is a very important guideline that is the first, and it's in press, and you'll be able to get it. This is figure 3 of the paper, which is in press in ophthalmology. And the authors who were listed earlier, many of them in the room. It was a tremendous good collaboration working together, led by Alison Scallett. What do my child's genetics mean for treatment and risk? So here's a family that has triplets, natural-born triplets, diagnosed because the first child on the left all children had a coloboma, so the pupils were abnormal shape. So the father took a picture of one to send to his colleagues. He was a pediatric family practice resident at that time, and that revealed a white reflex, which they had not seen before, and it turned out that all 6 eyes of these triplets had retinoblastoma. So that led us to label them all H1, and we discovered their retinoblastoma mutation, so we could test the parents, and the parents tested negative, but you'll see H0 at the top has a little asterisk on it because there's still a remaining less than 1% risk by all the calculations that one of those parents is a low-level mosaic that technology cannot detect yet. That would put their next babies at risk. Their already born child, the older brother, had a negative test, and his is a true negative because you can't inherit mosaicism. It can't be passed on. It would only be the first person of the family. The next baby in this family needs to be tested at birth and will likely be H0, but must be tested quickly by genetic testing. And then it gives us the opportunity in these babies, in these H1 babies, when you catch them early, shortly after birth, as this is one of these triplets. And you can see in the picture below, the RetCam image, it doesn't actually show any retinoblastoma tumors. We could see no tumors in this eye. But when we examined the eye with optical coherence tomography, we saw 5 tumors. And they are shown in that tiny little, right there is a little tumor. And then what we will have done at that moment is treat it with laser. This same laser is this green pointer. It's a green laser. So we would have lasered directly on that spot, using the OCT to know exactly where we should be because we still couldn't see the tumor. And then we did a repeat OCT to say, yes, we actually did hit the tumor with the laser, confirming it immediately. And we did that for all 5 tumors. And you can see 2 of the spots here of the scars later on, and they were all controlled with no chemotherapy, nothing else except laser. Compare that to this child who the mother had bilateral retinoblastoma, H1. The child was born full term because nobody talked about the pregnancy, her pregnancy, and the child wasn't looked at till he was 5 days old, and this is what he looked like. There's the optic nerve and optic nerve, both eyes with macular tumors, which were somewhat difficult to treat, particularly in the right eye. He still has 2 eyes with 2 scars, and he's very legally blind because of that. So that cost him that delay. If you'd taken that 5 weeks earlier for diagnosis, those tumors would have been much easier to treat, and he might well have had one of them, particularly his left eye. This tumor might have regressed down here, giving him a fovea and good vision. So this was recently published. We'd been doing that, delivering babies early in Toronto when we knew they carried their parents' mutation, but only when we knew they were H1. And Sammy Solomon led pulling all this data together over many years with many other authors who'd been fellows along the way, but we'd never quite completed it. And this reported 21 children comparing those who were born at the normal time, spontaneously, and they were HX at the time of birth, meaning we didn't know if they carried the mutation or not, versus those who we tested prenatally and knew they were H1 and delivered them early. And that has made a big difference. This is just the summary of that paper, with increased likelihood of children with no tumors at birth, giving us a chance to find them by OCT and laser them as they emerge, better visual outcomes, and less invasive therapy, less enucleations, less other things we might use to treat retinoblastoma. So the lifelong impact of being H1, we know, all of us, I think, in this room very much about the impact of radiation increasing second cancers. Just a little tangent on that. Many people who've died of their second cancers because they had radiation might be in this room today if there'd been a retinoblastoma study monitoring outcomes from radiated patients, and there was no study. So it took years to understand that there was an increased risk in second cancers because of lack of data collection. And now we know to avoid needless radiation, and we teach, and it's written in the Canadian guidelines, and maybe the Kenyan too, that the dental screening x-rays are unnecessary. The dentist can look at the teeth and poke little things in them and find out if there's cavities. They do not need screening x-rays. And so we arm our families to complain about it and say, no, I don't want any screening x-rays. I don't know what the status is in the community around that, but the only person who can defend themselves against screening x-rays by these very powerful, influential dentists is the patient themselves and their apparent advocate. So how many people in the room protest against dental x-rays? Good. Lifelong screening protocols is something that is not well developed. There's one good paper on whole body MRI screening out of New York, but it has to conclude that maybe the things that aren't cancer that are discovered on the whole body MRI outweigh the harms of not doing the whole body MRI at this moment. So the false positives, need to be carefully studied and make sure we're not doing more harm than good. So there's research protocols emerging in the US and in Europe, and I hope that they can work together. There's a very exciting meeting coming in February in Holland, putting together MRI whole body screening will be the major focus to pick up cancers early. And certainly it can work when all the details are worked out. I think actually the false positives, the area to be really focused on is not necessarily the technology. The machines are probably perfectly capable and giving adequate information to make a choice that that's a false positive, not a retinoblastoma tumor or a cancer. But it's the education of the people interpreting the MRIs that will lag behind the technology. So we have to all work together to make sure the radiologists doing retinoblastoma are really up to scratch and provide data from the research protocol for global screening and measure what is a false negative and what's real. And follow the example of the Honduras to actually measure, be sustainable in carrying this forward. And my question for the Honduras, which we can answer later, is you've managed to keep this program going. Have you published the results since 2007? Because it was very exciting what you showed in the last slide. I'd like to see that published so everyone can see what you achieved there. And then that maybe can be mimicked in the MRI study to be started. So I'm going to now pass to Melissa. There's the pointer.
Hi, I'm Melissa, and I have the unique situation of being both a bilateral retinoblastoma survivor and a genetic counselor. So I was really happy to be able to speak today a little bit about the genetics piece for those of us who have made it a little further along in life, and to talk a little bit about the importance of The importance of genetics, actually, for us. A lot of pieces have been discussed, but we survivors, we've had email lists, and now we have Facebook groups where we can talk about our questions. And it turns out that a lot of us still have questions about the genetics. What does it mean for us? Do I have a genetic mutation in every cell in my body? And if I do, how should I take care of myself and find out if I have a secondary tumor, primary tumor, and things like that. So I really believe that an understanding of genetics is going to be key for us and our lifelong care, and for us to be advocates, like Dr. Gallie was just saying no to those x-rays and things like that, and being a partner in our long-term care. So many of us are not involved in a survivor long-term follow-up clinic and things like that. Many of us are having to design our own, and would be very happy to be part of the research on the MRIs going forward, because we really do want to have appropriate guidelines and appropriate care for us to make sure that we take care of ourselves. And many of us are only finding out about our genetics either through the stories that are passed down through our family. So we get the information that our parents received about our diagnosis. For me, that was 40 years ago, and my parents were told that they had given me retinoblastoma, even though they were, I was the H1, and so they were told not to have any additional, counseled that it would probably be best not to have any additional children. So they had my brother, and so they luckily didn't really take that advice. But it really speaks to the importance of an of accurate genetic testing results for survivors, and also genetic counseling. I'm a genetic counselor, and I firmly believe that we need to have families understand these genetic test results and what it means for us for the rest of our lives once we've passed that treatment stage. So I think it's important. I think there's some research in process to look at parent understanding of genetic test results, because either we're finding out through our parents, through survivorship clinics, or through our own research. I actually had to do my own research to find out about the genetics, and inspired me to be a genetic counselor today, actually. So one of the things that we can do with our genetic information is actually have some options for our family planning, which is an important piece and near to my heart as a prenatal genetic counselor. So if we have access to our genetic test results, and we know that we carry mutation in every cell in our body, we can actually do some testing. About 50% of pregnancies are surprises. So in some cases, chorionic villus sampling or amniocentesis will be very helpful for families to find out, did the pregnancy inherit the mutation carried by the mother or the father. So CVS is really a placental test that's done earlier in pregnancy, between about 10 and 13, 14 weeks of pregnancy, and it can take several weeks to get those test results back. Amniocentesis is a test that's done more around 15 to 20 weeks of pregnancy, and usually we can get results a little bit faster, but it's done later, so that's one of the difficulties there. There is also an option of in vitro fertilization, IVF, with pre-implantation genetic diagnosis. This was an option that I actually personally used to conceive my children, so I can answer any questions that people have offline, since we have a very short amount of time to talk here. But it's actually a really difficult process. It involves a lot of effort on the part of the mom. There's a lot of medications involved, and it's not always covered by insurance. It can be upwards more than $20,000 per cycle of IVF with PGD, and so that can be very difficult. Maybe you have insurance coverage for PGD, but that is a small percentage of the cost of the entire procedure. So with IVF and PGD, you basically can biopsy the embryos that you create in vitro, and you can see which ones have inherited the mutation and which ones have not. And interestingly, it sounds good in theory, but in my case, I ended up doing 6 cycles of IVF with PGD to come up with a total of 2 unaffected embryos after many years of trying. And so although this seems like a wonderful idea, in practice, it does not always work. We don't always have an unaffected embryo to transfer, and many of us survivors, it's a very difficult idea. And we are here and we are doing really well. And so it's important to have quality genetic counseling for these survivors, so we can talk about all the options. We can talk about the new guidelines for how to care late in pregnancy for affected pregnancies, and also talk about termination. Anything that is important for a family. It's a very personal and important decision to feel supported in. So yeah, so I really hope that when you think about the care, the long-term care for adult survivors, that you have and realize that the importance of genetics, genetic information, and us having and being able to make informed decisions about our family planning and our screening later in life. Thank you. Oh, actually, and I didn't talk about the one small piece was the non-invasive prenatal testing for our RB1 mutation. So that actually is something that is really just on a research basis at this point. In prenatal genetic counseling, we do have availability, something called NIPT, non-invasive prenatal testing. It's a test of mom's blood. And in mom's bloodstream, there are little bits of DNA from broken down cells, but when you're pregnant, placental cells break down, cross the placenta, and end up in mom's bloodstream. So currently, we have commercially available tests to look for chromosome problems like Down syndrome. And it's still considered a screening test, but it is much more accurate than other screens out there, and there's no risk of miscarriage with those procedures, unlike the CBS and amniocentesis. So with the NIPT testing, on a research basis, there is the idea that you could look for a parent's mutation. It would be much easier if it was an affected father rather than a mother, but over time we may see availability. It may not be something commercially available because my current understanding is it's a case-by-case basis of designing a test for a family to do something like this. But it is an interesting potential future testing option, especially good for those who just want to do management later in pregnancy rather than making decisions about keeping a pregnancy. Thanks.
Thank you very much. We could take any questions if there's a pressing question right now. There are, 3, okay.
Is it on? Yeah. Okay. So I have a question regarding the full body MRI screening, but I have to give a little backstory first. So I was at work. I'm a nurse, and I was at work one day, and I had a very severe acute migraine that came on, and my manager sent me down to the ER, and the doctor was insistent that I had a CT, and I said, no, I don't want a CT. I get migraines. I just, I need Benadryl, I need, pain medication right now so I can finish working. And he kept arguing with me, I want to give you CT. And while I'm having a migraine, I'm having to educate this doctor about my RB history. And finally he said, okay, well, we'll do an MRI. So because of this, I was just curious because I have a wonderful doctor, actually, my family practice doctor, but I'm wondering the medical necessity question here. So if you say, I'm having an ache here, and I'm having all of these ailments, and I want to get these checked out, but how do you propose medical necessity to insurance companies saying, I would just like a full body MRI for peace of mind?
We'll come to that a little bit, not exactly that, but how do you, when you have payers who refuse on the basis of the cost of a test, like a whole body MRI, they don't want to pay for it. We'll address that in the context of don't want to pay for your RB1 mutation testing.
So I'm actually having yearly full body MRIs at the cancer center that I'm working with. So I'm working directly with a cancer center genetics team, and they worked with my insurance, and they gave the Lee-Fraumeni syndrome. It's another syndrome where they basically have long-term risks of many cancers for those, for people with a mutation, a P53 mutation. And so they basically used the data from screening those folks and said, look, RB is a similar model. It's not as high of risk as P53, but it is much less expensive to catch and to do an MRI and to catch a tumor early than it is to treat late stage cancer. And so they were able to make that case. A lot of times you have to do a peer-to-peer review with an insurance company for things like this, but if you can make the case that it's going to save them money over time, insurance can come around. Sometimes it takes some heavy lifting on the part of your care team.
Mark?
A question came in from the live streaming. How feasible is a global protocol for adult H1 screening?
My personal view would be it's entirely feasible when we have data. And so if we can put together the protocol for that screening as a clinical study, and then we will learn how to iteratively improve the process of the screening and how accurate it is and what not to do and what to do. So my answer would be perfect. Do it.
My question has to do with the dental X-rays, and it triggered my thinking about cell phones. There has been some talk that the radiation from our cell phones may be of some danger as well. Has that been addressed as to how that might affect a patient that's got retinoblastoma?
It's my answer to that question would be there's no radiation X-ray coming out of your cell phone, as far as I know. There may be other forms of energy coming out of it, but yeah, I don't think there's any evidence to speak to that. Yeah.
Kind of along the same lines, is there a thought about what are the factors that lead to the second hit? Radiation or other environmental influences?
The second hit appears from the data on way back to Knutson's data that the second hit is kind of intrinsic. The first hit may destabilize things, but maybe not. But maybe loss of the normal copy and reduplication or a second mutation is happening in all our cells all the time. 70% of the retinoblastoma tumors have the identical mutation as the second hit as the first. So that means that process of losing one piece of a chromosome and combining with the other may be happening all the time in all our cells normally. And it's only detectable when the outcome of that is a cancer. So you get that clone, that single cell that then's lost the second copy to start growing because it hits a tumor suppressor gene. So I think it's a normal process of our biology. We won't be able to reduce that impact. There's certainly nothing known about that. No. It would be complex to study that. You'd need H1 babies to count tumors, but there's other, I don't think that's happened at all yet.
Hi, I'm a parent. My daughter has bilateral retinoblastoma, and I had two questions. They're kind of related. First part, there was a point there that radiation increases risk of that secondary cancer, but from the readings that I've been doing, I didn't notice anything conclusive for plaque radiation therapy. So I wanted to see what your opinions were on that, and then also from back to developing secondary cancers. How much of it is derived from the treatment itself versus her genetics?
The first question, I'll pass to Brian to answer about plaque. Yeah.
I'm Brian Marr from Columbia, New York. Plaque brachytherapy is a localized radiation used to treat retinoblastoma. And I'll be talking about this tomorrow. The plaque itself is shielded, so the radiation content is focused on the tumor and shielded from the rest of the body. Though there is a low dose radiation that gets to the rest of the body, it's equal. When we did some studies on people that had pregnancies during plaque treatment, to about one chest X-ray to the rest of the body. So the amount of radiation with plaque is very limited externally in other parts of the body and surrounding tissues, but very high in the tumor areas that it's focused. So you get local side effects due to the radiation in the eye, but systemic ones are really on the low dose.
And contrary to the external beam radiation, which has absolutely very high risk for higher inducing second tumors, the plaques have no history of that at all. But on your second question, the treatment versus the H1 impact on the second cancers, it's the treatment. If you've avoided radiation, we think the major impact on second cancers is H1.
One more mother here. My daughter had a unilateral retinoblastoma. They didn't find any evidence of the mutation in her blood, and we literally just received the results of the tumor mutation. And actually what they found is quite surprising to me, and I was wondering whether you've seen this before or whether you could shed some light on this. Basically, they didn't find any mutation in the RB1 gene or any amplification of the MINC gene. What they found, and I'm translating directly from Spanish, so this might not be totally, but what they found is a gain in various genes in chromosome 6. We got the result, and the doctor was like, this is super rare. And actually, my daughter's presentation of the cancer was extremely rare as well, because it was a huge tumor by the time we caught it, and we don't think that we were late in cutting it. She has actually gone to ocularist quite often in her life, because we were afraid of some unrelated issues that had nothing to do with this. And we were quite vigilant about her eyes as well. But by the time they caught it, and it was within days of us seeing it was already a stage E, extremely big, we were told, for sure she's going to have high risk factors, and then they examined the eye and there was no risk factors, which was very surprising as well. So I'm just wondering, whether you've seen anything like that, and if so, what does that mean for the future?
I think for the tumors, the very rare tumors that we cannot find an RB1 mutation in, I'd love to see the data, I'd love to see the report, and that should then, that DNA should go into research studies. That's all I can say right now. We have to move forward, and we're going to get to some of the last little bit here. What do we do if we can't access genetic testing? And that's still got a B on it, yes. So the risks and benefits of genetic testing, I won't go through this slide because we've already covered all of this really today and yesterday. But I'll focus on, where's my slides gone? Oh, there they are, okay. How do we get genetic testing worldwide? This is a family that I treated, and I was very upset because the mother, right here, the proband, was a patient of mine many, many years ago, a very big advocate. She's led the Canadian guideline development. She's done everything, and we could never find her. She's bilaterally affected, could never find her RB1 mutation in her blood. So in the meantime, over the years, for her siblings and cousins and the offspring of the next generation all underwent EUAs looking for tumors in their eyes, dependent on their risk, following the new guidelines, in fact. And that would have cost a total in Canada, this is Canadian $2,004 when we first did this study, $62,000. And then, because we got better at looking at things, we found that she was a 5% mosaic, which you could have anticipated from all of this, but we needed to find that mosaicism. Because she was mosaic, that led us to know that none of these relatives ever needed any testing because you cannot inherit mosaicism. And her 2 children, which were already born, were negative for this mosaic mutation. She's had a 3rd child who's also negative for the mutation, as you might expect, because she's only 5% mosaic. And we hope her second cancer is also reduced to 5% instead of 100%. So that leads us to dollars. The cost of these EUAs, collectively, the cost of care, and that doesn't count the cost of care for an advanced eye because you didn't anticipate to look earlier. That cost is huge to the healthcare system. In Canada, we published data predicting this in 1996, and it took to 2006 to convince the Ontario government that they should be paying for genetic testing for retinoblastoma. So we had to have data like this proving it. So I would suggest that we all need to advocate with our insurance companies, with everywhere, to say it's in the interest of the insurance company to reduce costs. The cheapest way to get to better health care and cheaper care for H1 patients is by genetic testing. This applies also to breast cancer, exactly the same scenario. So they need to recognize, and even if you show them data, it may be hard to drive it through their thick skulls, but get to it, do it. And also think of what cost is. If you say, I can't, it's going to cost $2,000, my insurance won't pay, so it can't happen. But for the family who are being refused, what's $2,000? Do you have a television? Do you have a car? Think of what the cost value to you is, the impact of not having the genetic testing, and then it becomes quite cheap. But that isn't true maybe all around the world. So I'm just going to ask Hilary to very quickly address the Chinese RB partnership.
So there are many different roadblocks to genetic testing across the world, and one that we recognized in China is that they are not able to send samples out of the country for testing. So what we did I'm the lab director at Impact Genetics, is we're able to collaborate with the Chinese RB community. We helped them develop, and they created an in-house test using a new type of sequencing called next generation sequencing. They do the sequencing inside their country, and they send the data to us to interpret and to issue the report, which then gets translated back into Chinese. So this is a solution that they were able to overcome the challenges of their government of sending a sample out to internally provide the best of care to their retinoblastoma patients. And I don't know the details, but I'm hoping Helen can comment on the Kenyan ambition.
So our work in Kenya actually is because of World Eye Cancer Hope and its previous iteration as Daisy's Eye Cancer Fund, where a Kenyan national retinoblastoma strategy was developed. We couldn't look at genetics at the beginning. We started by looking at pathology. So when the eye is enucleated, what are all the steps to ensure we can look at it under the microscope reliably and know if there are high-risk features? We didn't, at that point, even cut out a piece of tumor for the purpose of genetic testing because we couldn't. But through that work, we developed really good partnerships with the University of Nairobi, and specifically with the Department of Human Pathology. And we're working together, linking the University of Toronto, the University of Nairobi, to expand training in genetics. Actually, this week, while we're here, there's a human pathology student in Toronto working with a lab that does next-generation sequencing. I had one of my students in Nairobi over the summer looking at all the steps needed to start doing something like this in the context of Kenya, working very closely with our colleagues there. As we heard from Lichia Fu, there's no shortage of brilliant people in low resource settings. It's just that their hands are often tied because of those low resources. So we're looking at expanding the capacity locally through ways that could sustain over time, and we think that by working within that university academic center, we can do that more reliably. We'll see. It's an ambition, as Brenda says.
Good. Thank you. I think we should move on. Thank you all for your participation, and we look forward to a day when everyone can have access to genetic testing.